Good afternoon, everyone, and thank you for joining us for today's webinar. For those of you on the West Coast, a pleasant good morning to you as well. Today's webinar topic is entitled Tuberculosis Today, Prevention and Treatment. And so our presenters for today's webinar would be Ms. Denise Dodge, who is a nurse consultant with the Virginia Department of Health, and Ms. Jane Moore, who is the director for the Virginia Department of Health TB program. Denise Dodge and Jane Moore from the Virginia Department of Health will focus on general information regarding TB and how TB has become prevalent in the United States. The presenters will discuss the role of the Virginia Department of Health in TB prevention and the difference between active TB and latent TB infections. Additionally, Denise Dodge and Jane Moore will provide information on the association between HIV and TB and methods of TB testing for all new HIV cases. And we do know that those of you who are health center programs, this is of particular importance to you as you see your patients with TB and HIV co-infections. After attending this webinar, all of you will have a better understanding of the signs and symptoms of TB infections. You will have a better understanding of how TB is spread between individuals and be more familiar with testing recommendations that can identify individuals who are affected by TB. And furthermore, you will be familiar with treatment options for individuals infected with TB and learn of available resources for U.S. providers treating TB cases. So without further ado, in order for us to maximize the time with our presenters, I will get ready to turn it over to them. I do want to let you know at the end of their presentations, they will take any questions and address any issues that you may have. So we ask that you would hold all of the questions until the end of the presentations, and we will give you an ample time to ask your questions. So again, I do want to thank Ms. Denise Dodge and Jane Moore for their time today and sharing their expertise on the call. So I will now turn it over to Ms. Denise Dodge. Thank you.
Well, thank you very much, Dr. Webb, and good afternoon and welcome to everyone. We at the Virginia Department of Health are pleased to have the opportunity to participate in this training webinar to offer basic information about TB to all of you. I'm hopeful we prepared information that will lay the groundwork for your anticipated role in caring for patients with TB infection. However, at the conclusion of this short presentation, you will be provided with resources for further review and study. The worldwide perspective of tuberculosis paints a dramatically different picture than what we see in the United States. Globally, one new TB infection occurs per second, and every 20 seconds, one person dies from TB. TB is the leading cause of death in the HIV population and is the second leading cause of death from an infectious disease. While we don't see that sort of morbidity here, the related impact on our soil is directly affected by the impact TB has around the world. The ease of movement from one continent to another has created a sort of superhighway for TB to be transported from one country to another. In the United States, we do have a healthy public health infrastructure which provides effective TB care and intervention. However, in other areas of the world, they're not as fortunate. Regions such as Southern and Western Africa have a higher incidence due to higher HIV incidence. Peru, Bolivia, Suriname, and Guyana have rates of TB above 100. And the TB Russian Federation, India, and much of Southeast Asia experience a higher incidence. These regions with higher incidence could be caused due to poor health infrastructures, TB that is drug resistant, HIV infection and AIDS, and poverty. So to bring this presentation closer to home, reported cases in the United States are at its lowest since 1953 when TB data was first collected. In the late 80s, an increase of cases occurred, which continued into its peak in the early 90s. This is attributed to HIV infection and AIDS, the changing immigration patterns, and an underfunding, which subsequently dismantled the public health TB program. While HIV infection rates have not decreased and immigration patterns have continued to bring individuals from countries with a high burden of disease, reported cases have declined. A total of 10,528 reported cases of TB in 2011 represents a 5.8% decline between 2010 and 2011. In 2000, 21 jurisdictions reported that over 50% of their TB morbidity was found in foreign-born populations. In 2011, the number of states reporting this disproportion of foreign-born cases increased to 34. That's over half of the United States. This increasing percentage of foreign-born TB patients presents a challenge to TB programs. The sheer number of different countries represented makes it impossible to have linguistically and culturally appropriate services at our fingertips for each case, so providing care is difficult. Using interpreter language lines, ensuring understanding of the treatment plan, monitoring for side effects or adverse effects requires a great deal of extra time for each patient visit. For those of you who currently care for populations that speak English as a second language, you have a first-hand understanding of how complex this can be. Here's a quick look at the breakdown of where our foreign-born TB cases come from. While Mexican-born persons represent the largest piece of the pie for an individual country, the category other countries that has the greatest percentage. And this category accounts for 139 different countries. The leading cause of TB disease in this population is more than likely due to them being infected in their country of origin, where TB rates can be quite high, much higher than in the United States. For example, in the Philippines, the incident rate is 280. In the U.S., it's 3.4. In Haiti, where reporting may be a bit unreliable, the rate is 238. In Vietnam, the rate is 200. India, 190. And China, 80. Upon arriving in the United States, they bring their TB infection with them, and often, within the first 5 years of arrival, progress to active TB. Now, I've included handouts with the material sent to you for this webinar. In those handouts is a list entitled Exception Countries. This list includes those countries that are not considered high incidence as defined by the World Health Organization. So when using this tool, if a patient comes from one of the countries listed, you would not consider them high risk. But note that all that are not on a list would be. To bring a perspective to the racial and ethnic characteristic of homegrown TB, this graph shows that approximately 2/3 of the TB cases reported in the United States are among minority populations. Black or African Americans represent the highest percentage of American-born cases, followed by Latinos. So I'm going to move on to a review of some basic principles about TB infection and TB disease. So what actually is TB? Well, tuberculosis is an airborne disease caused by Mycobacterium tuberculosis. It is a bacteria, not a virus, so can be treated with the correct antibiotics. There are many organisms in the Mycobacterium family that are related to TB, which are called non-tuberculosis Mycobacterium, or NTNs. You may recognize a common one, which is called MAC, Mycobacterium avium. These NTNs are not infectious like TB, and they're not transferred from one person to another. TB grows very slowly and has a tough, waxy covering. To observe Mycobacterium under a microscope, the laboratorian stains the specimen with red dye, then applies an acid wash to rinse the specimen. By a person who has infectious TB in their lungs when they cough, sneeze, talk, laugh, or stink. After enough of the TB bacteria enters the lungs, it undergoes some changes and begins to multiply. These events are called pathogenesis. TB flows into the tiny air sacs in the lungs called alveoli and begin to multiply. Within a short interval, the TB bacteria enter the bloodstream and spread throughout the body from head to toe. Within 8 weeks of infection, white blood cells, called macrophages, surround the bacteria and enclose them in a barrier shell, which will keep the TB contained and dormant about 90% of the time. The person with the infection will not feel ill and may not even know they were close to someone with active TB. At this point, a diagnosis of latent TB infection can be made. Now, latent TB infection, or LTBI, is diagnosed by a tuberculin skin test, or TST. It can take up to 10 weeks for a person to build up a strong enough reaction to respond to the TST. Do you need me to move?
That's right.
The TST diagnoses TB infection only and not TB disease. There's another blood test that I will talk about a little later that is currently being used to diagnose TB infection, called the interferon gamma release assay, or IGRA. I will talk more about that test later on in the presentation, but now let's take a look at who's at risk for TB infection. It's not. One moment, we need to. There are specific groups who have a higher likelihood of being infected than the general population in the United States. In the handouts is a copy of the TB risk assessment that is used in Virginia, which lists factors associated with an increased risk for infection. This can be used as a guide when you create your own risk assessments for your own facilities. To review a few on this list, let's take a look at close contacts with infectious cases of TB. This group is among your highest risk for infection. One of the most important strategies public health departments do to prevent further cases of TB is to carry out contact investigations surrounding infectious cases of tuberculosis. This activity locates close and vulnerable contacts, provides a medical evaluation, and then ensures appropriate treatment is given. This is a very labor-intensive activity, but is a proven strategy for decreasing TB morbidity. Immigrants who come from countries with a high incidence of TB, some mentioned earlier, for example, are infected in their country of origin before ever arriving here. And then moving to congregate facilities, well, they represent a particular challenge for preventing transmission due to the nature of how close residents live together. Examples of these facilities would be correctional facilities, homeless shelters, and also some healthcare facilities. At the end, you will be told of resources which will give you in-depth information on each of these categories for you to review and study. When deciding to perform testing for infection, an assessment of a person's risk for progression to disease is necessary. There are some populations that will not react adequately to a TST. The TST is not a perfect test and will miss 20% of those who are infected. Most groups that fall into this category are those who are immune suppressed, such as the HIV population. HIV infection is the strongest risk factor for progression to disease. Very young children are a risk group who will progress to active disease quickly after infection, so a lower threshold of risk is applied to them. You'll notice that the elementary and junior high school student ages 5 to 13 or so are not included. For a reason not clearly understood, this age group is less likely than other young people to progress to active disease. There are certain medical conditions that increase the risk for infection, which will be shown on the next slide. And an important group that has gained attention are those patients who are receiving TNF-alpha antagonists. Any individual who's going to begin therapy with one of these drugs, for example, Remicade or Humira or Enbrel, must be tested for infection before beginning this therapy. It's believed that they have as high a risk, or almost as high a risk, for progression to TB disease if infected as those with HIV. It is the standard of care to test this group for TB infection before treatment with the TNF-alpha antagonist is started. This chart shows conditions which increase a person's risk to progress from TB infection to TB disease. Silicosis is a form of occupational lung disease caused by inhalation of crystalline silica dust. Stone cutters, miners, and sandblasters run a risk of developing silicosis. It's common in developing countries but rare in the United States. The TST-positive persons with silicosis have an approximate 30-fold greater risk for developing TB. Now, those with diabetes, which is estimated to be almost 26 million Americans, their risk is increased 2 to 4-fold. So any medical comorbidity which affects the immune system's ability to fight infection increases the risk for a person to progress from TB infection to TB disease. When thinking about individuals who could have TB in their differential diagnosis, first think about the risk for infection, an example being foreign-born, and then determine their risk for progression. Generally, healthy individuals have a 10% risk over their lifetime of progressing to TB disease once infected with TB. The first 2 years after infection are the most risky. However, those with increased risk due to their immune suppression have increased risk for progression to disease. So suppose you are one of that 10% who do progress to active TB. How would you feel? General symptoms of TB are just that, they're general. TB located anywhere in the body can cause these symptoms. Fatigue and malaise, weight loss, for example, they're pretty nondescriptive. TB was once known as consumption or wasting disease. However, there are other conditions that can cause fatigue or a poor appetite, and also night sweats. It's important to include TB in your differential diagnosis when observing these symptoms, however. If TB is found in the lungs, a person will have a prolonged cough, normally lasting more than 3 weeks. They may complain of shortness of breath and chest pain, and eventually the symptom that brings them to the doctor is hemoptysis. This frightens them and convinces even the most stoic that they should probably be seen. Unfortunately, if it is TB, by this time they've already exposed many people. So we just reviewed general symptoms, and tuberculosis can occur in almost any site in the body. Symptoms could be present without a cough if TB is outside the lungs, and this is called extrapulmonary TB. Now, 85% of the cases do occur in the lung and are considered infectious, but 15 to 20% can occur elsewhere. The most infectious form of TB is when disease is found in the laryngeal area. So let's talk about extrapulmonary cases and what's the most common sites. Well, the kidney, the lymphatic system, the central nervous system, and bone. However, the portal of entry, remember, is always the lungs. It just spreads through the system and plants itself in these particular organs. Additional symptoms, other than the pulmonary ones mentioned, will depend upon what organ is affected in the body. So with these vague general symptoms and the variety of site-specific symptoms, what is the best way to diagnose TB? Diagnosing TB requires a thorough history for vulnerability to exposure and progression to disease, and a physical exam and symptoms review. We cannot overstate how important it is to think TB in order to diagnose TB. Many patients are seen in walk-in clinics or community health centers or other private healthcare facilities and treated for community-acquired pneumonia, bronchitis, or an upper respiratory infection, only to discover the true diagnosis is tuberculosis after 3 months have passed, and transmission in the community has occurred. The bacteriology is the second critical component. ASB smear and culture is ordered, and 80% of the time will be positive for a diagnosis of TB. However, unfortunately, about 20% of active TB cases do have a negative culture, and this could be misleading. Symptoms, as you learned earlier, can be quite vague in general. A history, a good TB history, combined with symptoms, will improve your chance that TB is appropriately diagnosed. Now finally, a chest x-ray that would be considered classic for TB would show abnormalities in the upper lobes of the cavitary. However, chest x-rays can vary and are not reliable alone for diagnosing TB. In some populations, like the HIV population, they can even appear normal. So making the diagnosis based purely on symptoms presented and the chest x-ray rarely raises a red flag for TB unless you have a suspicion for that diagnosis to begin with. So let's review. People with LTBI and TB disease have TB bacteria in their body and usually have a positive TST or IGRA. LTBI patients usually feel fine, have a normal chest x-ray, and are not infectious. A TB case presents with some symptoms, may have an abnormal chest x-ray, and is often infectious. As mentioned earlier, TB and HIV are a deadly combination. HIV is the strongest risk factor for progression to disease and presents some of the most difficult challenges for diagnosis and treatment. In practice, every HIV-infected patient should be evaluated for TB infection or disease annually. For those who are a TB case or diagnosed with LTBI, an HIV test should be done so appropriate interventions and treatment can be offered. Most TB is treated and cured with the first-line TB drugs. There's 4 of them: isoniazid, rifampin, pyrazinamide, and ethambutol. Now, over the past 30 years, we've been seeing an increasing number of TB cases worldwide that are resistant to 1, 2, or all of the first-line drugs. The primary cause is inadequate treatment regimens, and it is generally believed that the most widespread reason is non-adherence. The medications can have several unpleasant side effects, treatment is long, and there is a large pill burden. People of all races, ethnicities, genders, economic groups, or professions do not take antibiotic regimens correctly, or do they complete them. So adherence cannot be predicted. The health department provides a service called directly observed therapy to help prevent the development of drug resistance. Now, what directly observed therapy is, or it's called DOT, is defined as observing a patient take and swallow each dose of TB medications. This is done by a nurse, an outreach worker, or other trained reliable person for the entire duration of treatment. It is labor-intensive, however, well worth the effort. The cure rate for pan-sensitive TB is 95%. For drug-resistant TB, it can be as low as 50%, or in some cases, unknown. So some completely drug-resistant cases receive experimental treatment regimens and even may need surgery. So doing DOT to assure that patients take all of their medication is very valuable. An additional cause of inadequate drug regimens is when a clinician might prescribe an incorrect dose, medications, or frequency of administration. It's advised that any clinician who cares for a person with active TB does so with the assistance and guidance of their local TB program or their regional medical TB expert, unless, of course, you do see TB patients frequently. I'm going to switch again now, and we're moving to TB disease from TB disease and concentrate on LTBI. This is the population I presume most of you will encounter more frequently. The Mantoux skin test, better known as the TST, is the gold standard method for LTBI testing. Some of you may know this test by this name, PPD. PPD is actually the name of the solution you're injecting under the skin, not the test itself. However, the 3 have been used interchangeably. The TST has been around for 100 years or so. It's a very subjective test to read, and the results are not as reliable as we would like. In particular, with performing a test such as this, it's imperative that you do not skip specific important points when doing it. The better you are at considering each step of the process, the more accurate the results will be. So accurate results are dependent upon correct handling of the PPD solution and syringe. PPD solution must be kept cool and out of the light. The Centers for Disease Control recommends you do not pre-draw your syringe. So regardless of how many tests you're going to have to place, you should draw up just each one before administration. And also, the vial of PPD should be discarded 30 days after opening. A good history, as already mentioned, must be done. A risk assessment will help you know when it's appropriate to place a TST and how to interpret the measurement. The TST is an intradermal injection and requires practice to perfect. It needs to be placed on the correct area of the body. You must produce a wheel of 6 to 10 millimeters, and it has to be measured at the appropriate interval. If these steps are not followed, your result may be inaccurate. If after placing the TST you do not produce the expected yield, you should repeat the test immediately. It can be done in the same arm, a couple of inches away from the first one, or you can use it out the other arm. So I just want to stress that training is imperative to improve the results of this test. CDC TB guidelines recommend that any person with the responsibility of performing TSTs must receive training beforehand and be given an opportunity to practice until they are comfortable with administration. Information about courses to assist you in this training will be offered at the conclusion of today's presentation. We've already discussed risk for infection and risk for progression to disease and the risk assessment tool used in Virginia. Only those at higher risk for either TB infection or progression to TB disease should be tested. Bayes' theorem applies here. It states, the accuracy of a test is dependent upon the prevalence of the disease in the population. If you test those at risk, your accuracy will improve. This is why the importance of a risk assessment is so imperative. Reactions to TSTs are categorized into 3 different sizes, 5 millimeters, 10 millimeters, and 15 millimeters. The greater the risk for exposure and disease, the lower the threshold for the size of a measurement being considered positive. Details and further information is discussed in depth in the targeted testing guidelines you see here on this slide. Additional training is available for those who will be required to make assessment decisions. During this presentation, we wanted to be sure to briefly cover BCG vaccination because it can cause some confusion for patients and healthcare staff. BCG is a vaccine used in many countries throughout the world where TB is endemic. It's usually given at birth, and in some countries they give more than 1 dose. It can cause a TST to have a small reaction. However, almost 50% of babies who do receive a BCG do not convert their skin test. There are different strains, and some are better than the others. So they consider the vaccine's effectiveness to be variable, somewhere between 0 and 80%. BCG does not prevent TB infection. It does not prevent all TB disease, but it does lessen the severity of disease, especially in very young children. It seems to do a good job of preventing central nervous system TB in infants, which is life-threatening. In the United States, we do not use BCG routinely, but it is occasionally used in special circumstances, such as treating bladder cancer. CDC wants to make sure that everyone realizes the history of BCG vaccination does not preclude you performing a TST. It recommends you ignore the BCG history and measure and interpret the reaction as if the vaccine was not given. It is not harmful to place a TST if a patient has a history of BCG vaccination. Two-step testing is normally done as the first test for those who will be required to be serially tested, and it establishes a baseline result. Now, the booster phenomena is the principle behind the need to perform a two-step testing. So I'm going to try to explain this to you. Remote TB infection, which occurs many years in the past, may not react to the initial TST. A second TST is needed to boost the response to determine if the infection has occurred in the past. So let's look at this diagram. Starting at the top and going down the left side, a baseline TST is done, and it's negative. You're going to then repeat that test 1 to 3 weeks later, and the test is then again negative. In this scenario, the person is considered not infected with TB and will receive annual TSTs if that's what's required. This person's baseline is negative for TB infection. So starting again at the repeat of the TST on the left side, if the second TST is positive, the person is diagnosed with LTBI, or latent tuberculosis infection. But they consider this perhaps a remote infection. They will still need further evaluation, and in the future they will not receive any more TSTs. This person's baseline is positive, and the person is considered to have LTBI. On the right side of the diagram, the first test is positive. The person is considered to have LTBI and will need an evaluation, and they will receive no further TSTs in the future. This person has LTBI, and it is important to ensure that a positive skin test is not misinterpreted as a new infection. You have a handout of this diagram so you can kind of follow it through and keep it close to you, because this can be a confusing phenomenon to understand. Now I'm going to give you some information I have only mentioned but not elaborated on. About 10 years ago, a blood test was developed that was able to diagnose LTBI. This blood test has gone through several generations, and currently there are two very common tests used called the T-spot and quantiferon gold. We in TB Control were very excited about the development of this test, and many healthcare providers have adopted its use. CDC recommends that an IGRA may be used in place of a TST in all situations in which a TST is recommended. It is the preferred test for those who have a poor return for the reading because it only involves a single visit. If processed locally, results can be available within 24 hours. However, not all labs do have the necessary equipment to do this test, and it can be more expensive to perform than the TST. Now, there's no boosting effect. However, how it diagnoses remote infection remains unknown. As the IGRA is used more often, we will build a cohort of data on its use. At this time, we have limited information, and even though CDC recommends that you can use it, it is really not the preferred test for children 5 years and younger. Perhaps the most beneficial aspect of the IGRA is that it does not cross-react with the BCG vaccination. This has been a perplexing issue for years when testing with the TST. Where the TST could have a small reaction, both the T-spot and the quantiferon will not give you a positive result unless tuberculosis infection is present. So while we are pleased to have the IGRA in our arsenal for diagnosing LTBI, areas for additional research remain. For example, questions that still need to be answered are, what do discordant results mean between a TST and IGRA? So if a TST is positive and an IGRA is negative, what does that mean? Do IGRAs perform differently in children and adults? And those with extrapulmonary TB and pulmonary TB? And what about those people who are HIV positive or HIV negative individuals? Another question to answer is, how long after exposure does it take for an IGRA to be positive? And also, what effect, if any, would LTBI treatment have on IGRA results? Wrapping up this portion, I'll discuss treatment for LTBI. To caution all of you, after a TST or IGRA is done, if it is a positive patient, a patient must have a chest X-ray and a medical examination to rule out active TB disease before ever starting treatment for LTBI. So please remember that. A positive skin test without the appropriate evaluation following to ensure there's no TB disease can lead to some severe problems. Treating for LTBI is not normally an urgent decision. However, if you do treat the LTBI and a person truly has TB disease, the development of a drug-resistant form of TB is possible. At this time, there are 3 recommended regimens for treating LTBI. Isoniazid for 9 months, which I believe everyone is very familiar with, rifampin for 4 months, and the one regimen you may not be familiar with, and which I will spend some additional time on, is rifapentine and isoniazid for 3 months. Commonly known as 3HP, it's a short course treatment for LTBI that was approved 1 year ago for the treatment of LTBI. The most beneficial aspect of 3HP is its shorter duration. Individuals are more likely to complete treatment, which is the ultimate goal and way to prevent TB disease. With the traditional 9-month regimen, completing rates can be as low as 30% in some areas. With 3HP, completion rates have been shown to be much more encouraging. The disadvantages are listed. Currently, to provide 3HP, CDC recommends directly observed therapy. And I mentioned that earlier. That is when we observe the ingestion of the medication, ingestion and swallowing. And at this point, the regimen is not recommended for those with HIV, children 2 and younger, women who are pregnant, and those contacts to multiple drug-resistant tuberculosis. It can be more expensive, but the price has dropped significantly in the past year since being approved. We're sure that the more it's used, the less expensive it will be. This regimen is being used in a variety of settings with great success. So now I'd like to hand this over the microphone to Jane Moore, who'll give you the needed resources you need to continue learning about TB screening, testing, and treatment.
Thank you, Denise. Much of the information we have discussed this afternoon can be found in the major guidelines and publications put out by the Centers for Disease Control and Prevention. These various guidelines have become the de facto standards of care for all TB control activities and cover a wide range of topics, from treatment to infection control. I would like to encourage those of you involved in aspects of TB care to have copies of these documents that are pertinent to your functions available. The direct link for the documents is provided on the slide, but you can easily find these documents as well as additional guidance and educational materials by going to the website shown at the top of the slide, www.cdc.gov/TB. Today we have provided basic TB information about a number of topics based on national guidelines and information. Within states and localities, there may be slight variations in what is recommended and provided within that state that is within acceptable guidelines. I would like to encourage each of you to research the contact information for your state's TB control offices as well as for your local health departments. Many of you may already be aware of these people. Contact information for the various state TB control offices can be found at the links listed on the slide above. These agencies are your resources for state and local epidemiology, as well as local requirements for reporting, treatment, and other TB-related concerns and issues. Different programs may also offer various trainings within your states and localities, so that may benefit you as well. While much of TB control is universal across the country, there are also variations within state and localities that you need to be aware of. Since 2005, every state has been assigned to one of 4 regional training and medical consultation centers for both TB educational activities as well as expert clinical consultation for healthcare providers. These include the Curry International Tuberculosis Center in San Francisco, the Heartland National TB Center located in Texas, the New Jersey National Global Tuberculosis Institute in Princeton, New Jersey, and the Southeastern National TB Center located in Florida. All of these centers maintain websites as well as either a hot or warm line to both answer questions and provide needed medical consultation. They also provide information on their websites about their various training programs. The websites listed can also assist you in determining which center your state is assigned to. The centers offer live training programs and webinars both nationally throughout the country as well as regionally. They often offer on-site live programs within their assigned states. Each has many educational products for either patient or professional education, and these are available to anybody. They tend to be different on each website, and you are free to get the best of what's available on all the websites for your practice and information. Beginning next year, there will be an additional 5th site located at the Mayo Clinic, and the state assignments are going to be adjusted. So if you look today, please check back early next year to see if your state has moved from one center to another. In addition to the major guidelines and publications, a number of additional educational materials for both patients and healthcare providers can be found on the CDC website. Most state programs also maintain websites and contain additional training and education materials that are state and locality specific. And they also may provide links to both CDC resources discussed today as well as links directly to the appropriate national TB centers that may be of use to you. One last resource, as we talked earlier, we all deal with clients who either cannot read English or who are not literate in their own language, whatever that may be. A translated pamphlet, we think we've done great to provide something in their language, but it is not enough if they cannot read it. VDH TB Control, in collaboration with Healthy Roads Media, developed a series of TB educational materials that are not only available in written form, but also have audio and multimedia versions as well, i.e., they actually read the pamphlet aloud to the patient. In addition to TB topics, Healthy Roads Media on their website listed above have similar materials for a wide range of patient educational topics that you might find useful. These include such topics as hypertension, diabetes, and a whole host of health and health educational activities. Our contact information is listed above in case any of you have further questions that we don't get to today and would like to contact us. And now I'll turn the program back over to the moderator for questions and answers.
Thank you very much. Thank you very much, Denise Hodge and Jane Moore, for your presentation. It was very, very enlightening. We're going to open up the calls right now, the phones, for questions. And you can actually type your question directly into the chat feature, or feel free, if you would like to ask your question live, to use the raise hand feature. And then we will dispatch you directly through to our presenters. Also, everyone, please know that all slides and handouts will be emailed and available on our website following this webinar. This webinar has been recorded, and again, at the nchph.org, which is the National Center for Health and Public Housing.org acronym, you will be able to find an archived version of today's presentation. Devin, can you let us know if there are any calls coming in? Any questions? Sorry.
None at the moment. Hold one.
Okay, thank you. And so while we're doing, again, our presenters have provided their contact information. We will make it as well available on our website, and you can always feel free to contact any of us here at the National Center for Health and Public Housing, and we'd be happy to both provide you with some of the resources which we will link to our website, or connect you directly with our speakers. Denise and Jane, I want to thank you so much again for this presentation. I think for a lot of the health centers that see TB, unfortunately sometimes it's a disease that is not, we don't focus on it as much as we should, but I think you've shared a lot of information here that will get our health professionals to really think about including TB in their differential diagnoses. I do have a question coming in. I guess either one of you can answer. Can TST be given to a patient receiving vaccinations?
Yes, the TST can be given with many vaccines, and we don't have to necessarily think about the timing. The questioner is probably thinking of the fact that there is an issue with giving the TST with live virus vaccines. If you could give the TST on the same day as the live virus vaccines, it's perfectly acceptable. However, if you give the live virus vaccine first and don't do simultaneous TST, you have to wait 4 to 6 weeks after the administration of the live virus vaccine in order to be able to have accurate reading on your TST.
Mm-hmm. Wonderful. And how often can the TST be repeated in general?
As long as the results are negative, the skin test can be repeated daily, weekly. There's no minimum time frame between tests. If the skin test is positive, it is recommended that the skin test not be repeated. However, we all know that there are times and places that we need to have actually a documented reading. So the skin test can be repeated, not frequently, but it can be repeated if a person says they've had a positive reaction. They should be counseled that they may have a slightly more severe reaction than in the past. but basically there is no contraindication as long as it's negative to having frequent skin tests.
Okay, great, thank you. Another question we have is, what is the jejunal ileal bypass that you discussed early in your presentation?
It's intestinal surgery to remove a portion of the intestines, and depending on the section removed, it has been statistically linked to having a greater risk for progressing to active TB disease. It's looking at malabsorption, and I'm not, other than that, how it totally impacts the immune system and prevents the progression, attributes to increased progression is not fully understood, but it is statistically known that if you've had some major intestinal surgery and are infected, you're more likely to progress to active TB disease.
One of the questions that came through is, does TB affect the ethnic minority populations more than other populations based on what you've seen so far?
TB can actually affect any population, and many years ago it was a pretty common disease across all racial and ethnic barriers. As TB rates have lessened over the years, it has probably, you would say, retreated to certain ethnic and racial populations that have to do more with social factors than actually anything regarding their ethnicity and racial makeup. But it does have to do with poverty, overcrowding, and the usual social conditions that assist in promulgation of disease through communities.
Okay, thank you. What are the recommendations for a health center if the TB-infected let me make sure I'm reading the question correctly. What are the recommendations for a health center if a TB-infected patient visits? And what are the precautions, and what should they do when the patient has left?
I think you need to, the questioner needs to look back to the slide Ms. Dodge presented that shows the difference between TB infection and TB disease. Having the infection in the body people are not infectious, they cannot communicate the TB to anybody, and there are no special precautions that need to be taken. However, that is not true for a facility who may have someone who has active TB disease visit a client. If a person is we take care in public health to maintain people in isolation until such time as they are no longer infectious. Once people with active tuberculosis disease, through a number of criteria such as length of treatment, results on additional sputum testing, symptom improvements, maybe x-ray improvement, we determine they no longer present a risk to the community, and even though their treatment may last for many additional months, they are free to move about their community, and there are no risks to that person or to the community or any person they may visit in any kind of facility. For those people who are early in their treatment and they have not been released from isolation, those people should not be permitted to visit, and they should be escorted quickly from the building. Depending on the length of time that they were there, there may be nothing to do because the time period was so short. But that would be something for the facility to contact their local health department to determine what, if anything, needed to be done. Most people years ago, people may remember that people were sent away to sanatorium and isolated for many months and sometimes years. We no longer follow that practice in TB control. People are isolated at home until they're safe to move about the community, and they're able to be treated at home without, for the most part, without extensively long periods of isolation. There are variations to that, though, in the court case of drug-resistant TB.
Great. Thank you. How often should IGRA be repeated? Should they be performed on those already treated for LTBI, or is a cough screen or chest x-ray sufficient?
Okay, that's several questions all loaded into one. Basically, you would only need to do any testing for latent TB infection, either a skin test or an IGRA, when there's an indication to do that. We're looking at either somebody who is symptomatic and we're needing to determine the presence of tuberculosis infection, someone who is a contact to somebody, or things that we were mentioned, like taking those TNF alpha drugs. So those are certain indications, and it would only be necessary to repeat that in situations where one of those scenarios came up. There are a host of us who get tested periodically as part of an ongoing infection control program. The IGRA test would not follow at an increased, you would not do that any more often than you would a tuberculin skin test. Those tests, for the most part, and there are guidelines that you can find on the CDC website at www.cdc.gov/TB, that talk about the indications for use of those tests. We discussed them briefly here today. But those tests would only be used when there was part of the infection control program, and you would not do one or the other more often because it would just be the same schedule of testing. The second part of the question had to do with can you repeat the second part of the question? I'm sorry. Hello?
Yes, sorry about that. The second part of the question is, I'm just pulling back up the actual question here. Should IGRAs be performed on those already treated for LTBI, or is a cough screen or chest x-ray sufficient?
Yes. Once a person has been identified with latent TB infection, there is no need to repeat any skin test for latent TB infection. There are periodic symptom reviews like you talk about for the cough screen. You would also ask about the other general symptoms such as the fatigue, poor appetite, weight loss, night sweats. The general symptoms, you would sort of screen for all of them. And unless a person was truly symptomatic, there would be no need for any further testing or evaluation. Occasionally it comes up that an individual doesn't have their results, they're new to a job. As I mentioned, the skin test can be repeated at that time if you need documented results. Occasionally somebody may decide that they didn't take the treatment for latent TB infection in the past and they would like to consider it now for one reason or another. Again, they may not have documented results, and it would be okay to repeat the skin test, and probably prudent if you were actually going to start treatment. Again, you would actually, if somebody had a positive skin test, you want to make sure that they have a chest x-ray and any other medical evaluation or testing needed to make sure that they absolutely do not have active TB disease before you start a single drug for TB infection or treatment of latent TB infection.
Great. Thank you. The next question is rifampin the recommended drug for someone with LTBI who is from a country where drug-resistant TB is endemic?
Generally, people use one of the three regimens. Unless someone is known to be infected, meaning they're a contact identified as part of a contact investigation, to a known case of drug-resistant TB, we don't modify those three regimens of INH, rifampin, or now the new 3-HP regimen based on just surveillance information from countries. We cannot rule out when they became infected. Have they been infected for a long period of time because of exposure in their country when maybe the resistance rates of resistant disease was not so high in their country. So basically, it would still be isoniazid as the first choice, rifampin the second, or 3-HP as an alternative to either one of those. Rifampin is generally only used in situations where they are exposed to a known case of INH-resistant disease, and occasionally when people try INH and cannot tolerate it, that we move on to the second choice. A lot of times people want to switch immediately because the rifampin is shorter, it's only 4 months, but probably rifampin is the most important drug in our arsenal of weapons against TB, and if we lose that drug, if we make a mistake and treat somebody with a single drug who does have active TB disease, it doubles or sometimes even triples the length of time they have to be on treatment if they develop active TB disease down the road, or if we find later that they have active TB disease.
Thank you. I do not see any more questions on my side. Devin, do we have any more questions in the queue?
There's one more. I'm sending it over right now.
Okay, great. Thank you. Okay. So Devin, do you mind reading the question if you can see it? I can't see it on my end.
Are there any special testing or treatment guidelines you can suggest for those working with previously incarcerated populations?
Yes, on the CDC website that I gave you on the slide that showed the guidelines, www.cdc.gov/TB, there is, published in July 2006, there's a document entitled Prevention and Control of Tuberculosis in Correctional and Detention Facilities, Recommendations from the CDC. And that provides all sorts of wonderful information about how testing people who have been incarcerated, as well as infection control activities for correctional facilities. We do consider people who have been incarcerated as a risk factor and consider that those people should be tested for LTBI as a risk factor, just as if they were a close contact or had HIV or diabetes or any of the other risk factors we consider for those people at greater risk for having acquired latent TB infection. That would put them in a category for testing. However, the interpretation of the test remains the same, and then the treatment recommendations would remain the same if we find they are infected.
Great, thank you. And Devin, do we have any other last-minute questions coming in?
One more just came through. How long after a possible TB exposure does a patient need to be tested for TB?
After exposure, it takes the body, if they have become infected, and remember that probably 70 to 80% will not become infected, but of the 20 to 30% who do become infected, it takes the body 2 to 10 weeks after an exposure to produce the antibodies that would make a skin test or even an IGRA react. Generally, when health departments do contact investigations, we will go ahead and skin test contacts immediately after they're identified. We know when we're skin testing them, most of the time we're getting that first baseline test. Depending on how long that source patient has been infected, we may find that we find some people who are positive on the initial test, especially if it's been many months that we think this person has been potentially infectious to others. However, we then repeat anybody who was negative on the first test at least 8 weeks, and it's really preferred probably to do 10 or 12 weeks after the last possible exposure with the infected person, to repeat that skin test during that window period where they may be converting from negative to positive, to actually make sure that they have not converted their skin test or were not in the process when we did the baseline testing.
Great, thank you. So I think I would like to thank, first of all, Denise Dodge and Jane Moore again for such a wonderful presentation. I know our grantees have such a better understanding of the signs and symptoms of TB and the testing recommendations and options, as well as the available resources. So thank you for sharing all of this information. Again, we would like to thank all of you, our grantees who have taken the time out from your busy schedules to participate on this webinar topic. We know that the information has been helpful and useful to you, and you will receive a post survey that we ask you to kindly complete so that we can continue to evaluate and bring the training and technical assistance needs that you desire. And again, thank you, Denise and Jane. This has been a phenomenal presentation, and we know that this information has been very enlightening. We do have the presenters' contact information on our web, and again, please visit us at the nchph.org website, where you can retrieve an archived copy of today's presentation. Thank you, everyone.
Thank you.
Thank you.